So my name is Abdraman Anthony Kilonzo. So I'll be taking you through rheumatic heart disease, ischemic heart disease, and hypertensive heart disease. It was a session that was forgone to today. It was supposed to be done last week. So we'll go ahead and start. Okay. So we want to start by looking at rheumatic heart disease. Yeah. And if you remember very well in the microbiology slides in year 2, I think year 2 or year 3, when you were reading microbiology, there was a certain statement that was made by, it was in the slides of Dr. Miriam Mureithi, that said a sore throat broke the patient's heart, or a sore throat leads to a broken heart. Yeah, you all remember that. So, what does that mean? What does the term or the saying a sore throat broke the patient's heart mean? Yeah. So every time a patient or every time a person has a sore throat, so then there is a possibility that that person at the end of it all may have a broken heart. Yeah. Or something is going to happen to the heart that is going to be as a result of the infection that was caused by a bacteria that leads to the development of a sore throat. So when you're talking about rheumatic heart disease, then we should always be thinking about a sore throat. Yeah. So this is an infection that led to pharyngotonsillitis. Then later on, it leads to a heart disease, particularly a valvular heart disease. And that is why when you're talking about rheumatic heart disease, most of the times you'll hear people talking about valvular heart disease, because the most common the most common cause of vascular lesions in the heart, not vascular but valvular lesions in the heart, is rheumatic heart disease, and therefore rheumatic heart disease is equivalent to valvular heart disease. Okay, so rheumatic heart disease is a sequela, yeah, or is a consequence of rheumatic fever. Yeah, and you all remember what rheumatic fever was. You all remember group A streptococcus, the beta hemolytic. Yeah, so the group A streptococcus, that is the Streptococcus pyogenes, is the bacteria that we are interested in. Is the bacteria that causes tonsillopharyngitis, amongst other infections, like, for example, scarlet fever and other clinical manifestations that are due to the infection by this gram-positive bacteria. Yeah, you all remember that that is the Streptococcus pyogenes is a gram-positive bacteria, and so some of the virulence factors that are going to be endowed in this bacteria are going to be found in the cell wall. Okay, so we are saying that rheumatic heart disease is a sequela or a consequence of rheumatic fever caused by group A streptococcus, or what we refer to as beta hemolytic streptococcus. So you all remember the pathogenicity or how it happens, eh? So you all remember that the components of the the cell wall. Yeah, remember it's a gram-positive bacteria, and so it has a thick peptidoglycan in the cell wall. Yeah, so you remember the hyaluron, all produced by the hyaluronidase enzyme, not hyaluronidase enzyme, streptokinase enzyme, peptidase enzyme, pyrogenic toxins, reptolysins, and all these are what are contributing to the to the pathogenicity or the violence of the bacteria. And for example, taking the case of hyaluronidase enzyme, yeah. So hyaluronidase enzyme breaks down hyaluronic acid, which is found in connective tissue. Okay, and when this hyaluronidase, for example, enzyme is released into the joint capsule, it digests the joint capsule that is made up of hyaluronic acid. Hyaluronidase enzyme breaks down hyaluron, which is found in the capsule of the joints. And that is why one of the clinical manifestations of rheumatic fever is migratory joint pains. Okay, streptokinase, which breaks down clots Yeah. And then peptidase enzymes that breaks down the, remember, when your body is fighting infection, it produces immunogens, it produces cytokines, it produces various components that are protein in nature. And all these proteins are broken down by the peptidase enzyme that is produced by the bacteria, and therefore contributing to the virulence. Okay. So every time you produce an immunogen, for example, a cytokine, and then a counter effect is produced by this bacteria, so this enables the proliferation of the bacteria and therefore continued production of maybe pyrogens by the bacteria, and that is what gives the constitutional symptoms of the rheumatic fever. Why is it called fever? It's called fever because one of the presenting features will be what? Will be high temperatures. The constitutional symptoms of rheumatic fever will be hotness of body, that is high temperatures, and fatigue, generalized body malaise. Remember all those constitutional symptoms of rheumatic fever. Okay. So, and this is due to the production of the pyrogenic toxins that are produced by this bacteria. Remember, all these are virulence or pathogenicity factors that are possessed by this bacteria to enable it to survive. And as in the process of its survival, it causes more harm to the body of the patient who is infected. Okay. So that is what you learned in immunology. So we are focusing on the pathology bit, but it's good to correlate the pathology and the immunology. Okay. So what are the risk factors of one developing rheumatic disease or rheumatic fever? Remember, this is a bacteria, just like streptoneumo, that is spread through aerosols. Okay. So if a patient has pharyngitis, for example, through aerosols, he can transmit the streptococcus bacteria to another person. Okay. So therefore, and that is why this is very common in children. Yeah. So in places that are overcrowded, in places where they are, in low socioeconomic status, for example, in African countries, actually, rheumatic heart disease is the leading cause of valvular heart diseases in Africa and in other countries where there is low socioeconomic status. Okay. And then we also have antigen presenting cells which bear the HLA-DR7 antigen, okay, in their cell membrane. Remember, the antigen presenting cells are the ones that are going to pick up the M proteins or break down okay. We are talking about Streptococcus pyogenes, which is a bacteria. Okay. So once it is in the body, for example, when it reaches the tonsillar area or the pharynx, what happens is the antigen presenting cells at the surface of the pharynx are going to pick up this bacteria and present it to the T cells. Okay. And then the T cells are going to be activated and they are going to induce or to activate B cells that are going to produce antibodies. Okay. So the antigen presenting cells, the ones that bear HLA-DR7 on their surface, okay, increase the possibility of a person developing rheumatic disease after getting a rheumatic fever, because the antigen presenting cells that bear HLA-DR7 have increased possibility of picking up the Streptococcus pyogenes and presenting it. And then after that, what happens is cross-reactivity with the proteins that are found in the joint capsule, proteins that are found in the heart, proteins that are found in the basal ganglia, and then result in type 2 hypersensitivity reactions, and this is what is going to lead to rheumatic heart disease. Okay. And then another risk factor is the heart tissue protein. Okay. The M protein. Certain subtypes of the heart tissue protein increase the possibility of one getting rheumatic heart disease. Okay. Remember, not everyone gets rheumatic fever and ends up getting rheumatic heart disease. Maybe about 60% of patients who get rheumatic fever are going to get rheumatic heart disease because of these predisposing factors. Okay. So what happens after the infection? So a person gets a tonsillitis or a pharyngitis. Okay. And then after this infection, maybe after 3 weeks of latency, then the clinical features come about. Okay. And these clinical features are mostly noted in the heart. Remember, we've talked about the heart tissue protein. Okay. And the cross reactivity between the antibodies are produced by your immune cells against the M protein that is found on the surface of the gram-positive Streptococcus bacteria. Okay. So then again, we also have the brain, especially in the base of ganglia, the stria part of it. And then we have the stratum, not the stria. And then we have the joints because of the presence of hyaluronidase. You remember the okay. This is going to hyaluronic acid, yeah, that is found in the joint capsule. And remember, this is going to be targeted by the hyaluronidase enzyme that is produced by the gram-positive Streptococcus. Okay, and then we also have the skin, yeah, and that is why there is this mnemonic of jaundice. That is the clinical features of rheumatic fever. Yeah, we have joint pains or looking like the heart, that is pancreatitis, and then N, that is the nodules, okay, the skin nodules, and then erythema magnetum. You remember the hyperpigmentation of the skin, and then we have the S, which is Sydenham chorea. Remember, we said that one of the places that is targeted by the antibodies that are produced or by the components of the bacteria would be the basal ganglia. Okay, Sydenham chorea. Remember the involuntary movements of the hands and other parts of the body in a patient who have rheumatic fever. Okay, so that is the mnemonic. You remember the clinical features of rheumatic fever, that is joint pains. And the heart, the O is representing the heart, that is the pancreatitis, and then the migratory nodules, the migratory skin nodules, and then the erythema magnetum, and then the Sydenham chorea. Okay, so how does this happen? Remember, we've said normally your body is supposed to mount an immune response against any invading pathogens. So what happens is that the immune system innocently mounts an immune system against the Streptococcus pyogenes bacteria. Okay, but the antibodies produced after your immune cells, the antigen presenting cells, have presented the antigens to the T cells, and the T cells are producing antibodies against the M proteins. There is cross reaction. Because you remember, antibodies have what we refer to as affinity and avidity, all those ones you can go and look at from your immunology lectures. So, but an antibody and an antigen can cross-react with antigens. An antigen can cross-react with another antibody that is not produced against it. Okay, so and therefore, in this case, we are going to have antigenic mimicry, or what we refer to as antibody cross reactions. And this is what type of hypersensitivity reactions, if you remember? This is type 2 hypersensitivity reaction. Okay, so in any case, they ask you what type of hypersensitivity reaction is shown when there is cross reactivity between the antigens that are produced by the Streptococcus pyogenes bacteria and the antibodies that are mounted in defense by your immune system. That type of hypersensitivity is type 2 hypersensitivity because it is antibody antigen cross reaction. Okay, but you remember something called post-streptococcal glomerulonephritis. Okay, you all remember those things that lead to nephritis, nephrotic syndrome, that as a result of a post-streptococcal infection. Yeah. So you go look at it and compare between that and the rheumatic heart disease. Yeah. And then look at which type of hypersensitivity it is. Okay. So we have the type 3 hypersensitivity reaction versus the type 2 hypersensitivity reaction. So you go look at it. But the the rheumatic disease is a type 2 hypersensitivity reaction from your immunology classes, while the post-streptococcal antigen antibody complexes that are deposited in the basement membrane of the glomerulus. Okay. And that type of hypersensitivity is what we refer to as type 3 hypersensitivity reaction. So basically, go look at all the types of hypersensitivity reaction and ask yourself which one is in rheumatic heart disease. We've said it is type 2 hypersensitivity reactions, and which one is in post-streptococcal glomerulonephritis, and you'll find that it is type 3. Okay, maybe when you're doing your revision on hypersensitivity reactions. Then, because of this cross reaction between the antibodies that are produced against the M proteins, this is what leads to this sequela, what we are referring to as rheumatic heart disease. About 60% of those patients who get rheumatic heart disease can end up, that is, those who get rheumatic fever can end up getting rheumatic heart disease. Okay. And remember the risk factors for you to get rheumatic heart disease. One of the predisposing factor is the what? If you remember, is if your APCs, your antigen presenting cells, your dendritic cells, your macrophages, your plasma B cells, if they are bearing the HLA DR7 on their cell membrane. Okay. And then again, if your heart tissue protein is bound to get, it has increased risk of developing rheumatic heart disease. So not everyone who gets rheumatic fever will end up getting rheumatic heart disease. Okay. So again, I want you to ask yourself whether you remember the M proteins, okay, the cardiac myofiber myosin protein, and what happens. Just remind yourself the pathophysiology again. Okay. So remember what you have said about the pathophysiology. So now let's get to the pathology. So the reason why I'm getting to the immunology bit and the pathophysiology bit of it is most of the times when you get a question on rheumatic disease, they don't ask you just about the pathology, but they can ask you about epidemiology. They can ask you. I remember we did a question on rheumatic disease, and they were asking about the clinical features, the pathology, the pathological features. I don't remember the other bit, but they will not ask you just about the pathology bit. They can ask you about the immunology part of it. They can ask you about other things concerning rheumatic disease. And remember, it's one of the most important disease that we study in pathology. So make sure that you are conversant with it. Okay. So that's it about rheumatic fever and how it leads to rheumatic disease. Then, so pathologically, what are we expected to find? Okay. If we get a heart of a patient who had rheumatic fever and we did some microscopy after postmortem, we are going to see what we refer to as ash of bodies. Okay. That is in rheumatic fever. Remember, not in rheumatic disease. Okay. So in rheumatic fever, because we are having the cross reaction between the antibodies that are mounted by your immune system and the tissue, the heart tissue protein. Okay. So we're going to produce, because of the inflammatory bit of it, because remember, we are inducing an immune reaction. And so an inflammatory response is going to come about. So your collagen, yeah, is going to get swollen. And then we are going to recruit lymphocytes. Okay. We are going to recruit cells into the site of infection. Okay, and particularly this is the valvular area. Okay, so we are going to have the collagen is swelling. And why is it swelling? Because of inflammation. And then we are recruiting cells to the site of infection, that is lymphocytes and T cells. All these are going to come together, as well as the macrophages. Remember, the macrophages are the main antigen presenting cells. And here they become giant macrophages. And that is what we refer to as an issue. Because what they do, there is syncytial formation. Macrophages collude. They join together to form giant cells. And then this occurs in the different layers of the heart muscle. So in the myocardium, in the pericardium, and in the endocardium, in between. And that is what brings the picture of the bread and butter appearance. Okay. Remember, these are getting deposited in between layers. Okay. In between layers, just the bread and put your butter in between. Okay. Or put your Bloomberg in between. So we have deposition of, because remember we are mounting an immune, your lymphocytes, all in between. Remember, one of the features of rheumatic fever is pancreatitis. And you're talking of pancreatitis, that the entire wall of the heart is involved. So in between, in the myocardium, the pericardium, and the endocardium, from the outside to the inside, in between all these layers, we are going to have deposition of this ash of bodies, and that is what gives a bread and butter appearance. So if they give you a bread and butter appearance, for example, in a microscopy slide, or maybe in some diagram, and then you're supposed to tell what it is, that is not rheumatic heart disease. It is rheumatic fever. Because remember, rheumatic heart disease is a sequela. Okay? An inflammation, remember what Dr. Waweru keeps on saying, inflammation leads to scarring, healing with fibrosis. Okay? So that fibrosis stage is what we are talking about, rheumatic heart disease. But in the inflammatory stage, in the early phases of the disease, this is rheumatic fever. So anytime you see a bread and butter appearance, bread and butter pericarditis, that is what we refer to as ash of bodies, and that is seen in rheumatic fever. All right. So now we continue to gross. Microscopically, we've said we are going to see ash of bodies. And then you can see bread and butter appearance in pericarditis, maybe a gross picture. And then grossly, we're going to have vegetations, okay, in the heart valves. And that is what we refer to as verrucae, okay? And these vegetations are the vegetations of the bacteria. Remember, in the early stages, we have the body has mounted an immune response, but it has not cleared the bacteria. So the bacteria in the heart valves is going to multiply and form vegetations. And that is what we are referring to as verrucae. And you can see that grossly, okay? And then they form some sort of plagues in the left atrium, particularly in the left atrium, because remember, why is it that the mitral valves and the aortic valves are the ones that are preferred by the Streptococcus bacteria? Okay, this is because of the hemodynamics of the left side of the heart. Because remember, this is where high pressures are. Okay, so because of the hemodynamics of the left atrium, of the left side of the heart, that is where we have most of the valves getting involved, all right, because of the high pressures. So we'll have verrucae and the McCallum's plague that is found on the left atrium, particularly because that is where the mitral valve is, all right? Then what are you then going to find in rheumatic heart disease? Remember, rheumatic heart disease, again, we have inflammation happening in rheumatic fever. Then there is healing with fibrosis. That is what happens in the late stages of the disease. And that is what we refer to as rheumatic heart disease. So what do you find grossly? Grossly, we are going to find scarring and calcification. Because when you're having fibrin getting deposited, and then the transformation of the fibrin into calcium deposits, okay? Because we are healing with fibrosis, okay? So when you do a post-mortem of the heart, grossly, you're going to find valvular and large vessel lesions, okay? And we're talking about large vessels, we are talking about the atria, and not the atrium, but I mean the aorta and the pulmonary, particularly the aorta. You're going to find lesions, okay? Large vessel lesions and the valvular lesions. And this is because of the areas where we're having healing with fibrosis. So we're going to find again the valves are going to be fibrosed and calcified. And how you find calcified lesions, you'll see whitish spots on the valves, okay? Then the valves are going again to be thickened, not as normal, and then deformed, yeah? Remember how they're supposed to be? They're supposed to be flexible, floppy, and then they change, they become thick, they become deformed, and then they become retracted. Then the commissures holding the valves again will fuse, they'll shorten, and then the coda will also be thickened. And that is what you're going to see grossly, okay? Microscopically, you can see calcium deposits on a histology slides on areas where ash of bodies was supposed to be. Remember, ash of bodies were seen in the acute phase of the disease, that is in the acute rheumatic fever. So that's it about what you are going to find in the pathology, grossly and microscopically. Remember, grossly, you're going to find those valvular lesions in the large vessels and in the valves. And then the thickening, the shortening, and the fusion of the commissures and the thickening of the coda. And then microscopically, you'll find deposits of calcium, and that happens in the areas where ash of bodies were. Okay. So they can also ask you about the clinical and structural consequences that you'll find in a patient who has rheumatic heart disease. Okay. Remember, mitral valve almost always affected, okay, because of the hemodynamics, because of the pressures of the left side of the heart. So the mitral valve and the aortic valves are the ones that are mostly involved. 65, 25, 65% aortic, that is mitral, then 25 the aortic, and then the rest, that is like in a tricuspid and the pulmonic. Pulmonic is really involved, the tricuspid is also really involved. The mainly valves that are involved are the mitral and the aortic valves, okay? So when the mitral valve is involved, remember, it thickens and shortens. And then what again happens is that these valves will be no longer floppy, okay? So they'll give a certain type of appearance. Yeah. Remember the buttonhole appearance? Yeah. Or the fish mouth appearance. That is what is in mitral stenosis. Okay. So mitral stenosis, mitral regurgitation, those are structural consequences of rheumatic heart disease. Okay. Because this is a valve, it has thickened, it has shortened. So the valvular space is reduced. So what is going to happen? Stenosis and regurgitation, okay? And because of stenosis, what is going to happen to the left atria? Remember, it's not going to be emptying fully, because now it is emptying through a stenosed valve. So what is happening is that the blood will be accumulating in the left atrium. And so what happens is that the left atrium will be dilating, okay? So there will be dilatation. And because of dilatation and the blood is going to be having stasis, there is hemostasis. If there is hemostasis, what is going to happen? There is increased risk of venous thromboembolism. So what is going to happen? A neurothrombi is likely to form. And if there is a neurothrombi that is likely to form, what is going to happen? There is increased risk of ischemia, okay? Because remember, The commonest site in which a clot or a thrombi from the heart can be thrown is in the brain, okay? So therefore, there is a possibility that the patient with mitral stenosis is likely to suffer an ischemic stroke, okay? Because there is a likelihood of formation of a mirror thrombi, and the thrombi is likely to be thrown from the heart to the brain, okay? So some of the consequences, clinical consequences of rheumatic heart disease, okay? Then the right ventricle is also likely to hypertrophize, okay? And why is it likely to hypertrophize? Remember, we have stasis in the left atria. So blood is accumulating and going back through the pulmonary vessels back and causing congestion in the pulmonary system, in the lungs, okay? And then later that effect is going to be superimposed onto the what? Onto the right ventricle, okay? And so the right ventricle has now to try to generate more pressures to be able to pump this blood that is accumulating from the right ventricle now through to the lungs and then back to the left side of the heart. So what is likely to happen is that the right ventricle is trying to hypertrophize, and when it can't hypertrophize any further, it's going to fail, okay? And because the right ventricle is failing, it's going to likely cause a left ventricular hypertrophy again now to try to compensate. So the left ventricle is also likely to fail in form of compensatory mechanism, okay? So because of this hypertrophy, we're likely to get a syncope. Why a syncope? Because they're likely to be a reduced perfusion and angina. Of course, what we've been talking about in the previous discussions, okay? Yeah, so some of the consequences are those. All this due to mitral stenosis, okay? And why the mitral stenosis? Mitral stenosis is coming because of calcification of the valves. They can no longer be flexible. They can no longer be able to allow or to prevent backflow of blood. Okay, remember the main function of valves is to prevent backflow. Okay, but when they are failing, then what the other consequences other than stenosis? We are going to have regurgitation. Okay, so mitral regurgitation is one of the consequences of another consequence of rheumatic heart disease. Okay, and due to the incompetence of these valves, therefore blood is going to be flowing back. Okay, so remind yourself about what type of pulse you're going to get in mitral regurgitation when you do your clinical examination. Yeah. So what type of pulses? Remember the bounding pulse of mitral regurgitation, eh? So you should remind yourself on your examination, if a patient has mitral regurgitation, what type of pulse you get. And because of this stasis and this regurgitation, yeah, so we're likely to get infective endocarditis. One of another consequence, another clinical consequence of rheumatic heart disease. Okay. Why infective endocarditis? Because we are having stasis, bacteria would find a good environment to grow and therefore cause a vegetation. And this infective endocarditis, remember, can form emboli, and these are still consequences of rheumatic heart disease. Right? Then other valves, again, we've talked about the aortic valve, about 25%, and others like the tricuspid. But remember, if you find a tricuspid regurgitation, for example, or if you find tricuspid stenosis, one of your top differentials will not be rheumatic heart disease. Okay? Remember, patients who inject themselves, yeah, IV drug users, yeah. So infective endocarditis in IV drug users is the commonest cause of tricuspid regurgitation and tricuspid stenosis. Yeah. So it is not rheumatic heart disease, but rheumatic heart disease can also lead to tricuspid stenosis and tricuspid regurgitation, and the carcinoid syndrome as well. Okay. Remind yourself what carcinoid syndrome is. If we have tricuspid regurgitation, for example, or tricuspid stenosis, what is going to happen to the right atrium? So we are not having complete emptying of the tricuspid of the right atrium. So what is happening is that the blood will be accumulating in the right atrium. So the right atrium is going to undergo dilatation. If it undergoes dilatation, then what happens? There is again congestion and blood flows back, or there is stasis in the right side of the heart. Okay, so consequences will be including peripheral edema. Yeah, because now the blood that was coming through the inferior vena cava and the superior vena cava will be accumulating in those vessels, and therefore, clinically, you'll find these patients will be having peripheral edema. So they'll be coming with fatigue, they'll be coming with exertion or dyspnea and those features of heart failure. Okay? So that's it. Other consequences include myocarditis, pericarditis, endocarditis, that one we talked about, and pericardial effusions. Yeah. Remember, one of your differentials, if you have pericardial effusions, one of the top differentials will be heart disease. Okay, and one of the heart diseases that is likely to cause pericardial effusions will be, remember, the effusions can either be serous or what? Or fibrinous. Okay, so remind yourself the differences between serous or fibrinous and fibrinous effusions that are caused by heart diseases and other types of diseases. Okay, remember, not only heart diseases can cause pericardial effusion. Yeah. All right, questions about rheumatic fever and rheumatic heart disease. Okay, so I have a slide here. Okay, I hope all you can see. Well, I don't know whether I lost everyone. I've been talking to myself. Hello, can you hear me? Hello?
Yes.
Can you hear me?
Yeah, we can hear you. Continue.
Okay, all right. So you have a question here. And the question here I posted one was, what other major disease causes pericardial effusion other than rheumatic heart disease? And what type of effusion does it cause? Anyone can tell us, other than rheumatic heart disease, what other major disease causes pericardial effusion other than rheumatic heart disease? And what type of effusion does it cause? You remember tuberculosis? One of the consequences of pulmonary TB is that it causes pericarditis. Okay, and go look at what type of pericarditis it causes, whether it's serous or fibrinous pericarditis, and remind yourself again the differences between exudative and transudative effusions. Okay, so what valves are affected in rheumatic heart disease? I can't see the chart, so I cannot be able to look at it. So if you're typing, maybe somebody can shout the answers from the chat box. But we already talked about this. What valves are mainly affected in rheumatic heart disease? I hope you can all hear me. Well, we said that the main valves that are affected are the mitral valves, 65%, 25% aortic, and then in combination, most of the times, almost always will be the mitral, and then the aortic, and then rarely find the tricuspid, and the pulmonic valves can also be affected. So what can you see in this diagram? Okay. If you zoom it, you can see those areas, those central areas. If you look at this, a histology of the heart muscle. Okay. And this is smooth muscle bundles. You can see them around, but there is this central area. Okay. So you can see what looks like. So you can see these areas. I don't know whether you can, I don't have a pointer. I don't know how to operate it, but the central area is showing ash of bodies. Okay. So you can see these areas of dark looking like nuclei. So we have the ash of bodies. Yeah, that is what you can see. So you can see that central area that looks whitish, and then those dark areas central with darkened nuclei. So those are the multinucleated giant cell, the initial cells. Yeah, all these forming this lesion-like area, that is the ash of bodies. So this large central area is the ash of bodies with the multinucleated giant initial cells, and then the neutrophils, not the neutrophils, but the lymphocytes, all this as an infiltrate. Okay, so you will look at that question again. Let's move on. The next question. So you can see that question there. And the question was, what can you see? If you are told to describe the pathology, you will describe. So those are the commissures. You can see those what do you call those tender coda tendinae? You can see what the arrow, the red arrow is showing you. You see those verrucae? Remember what we described in rheumatic fever? Those vegetations that are pointed by that arrow. Okay, so that arrow is showing you those vegetation, the pus-like structure, those pus-like lesions. So that is the verrucae, and that is in rheumatic fever. Okay. All right. So we move to the next. The next question you can see. The question is, what pathology is this, and what condition is it associated with? If you zoom again, you can see that looks like a buttonhole or a fish mouth. And that is what we see in rheumatic heart disease. Yeah. So that is mitral stenosis. Mitral stenosis is the pathology. You can see the description. If you were to describe it, you will say it looks like a buttonhole or a fish mouth, and that is mitral stenosis. In what condition? In rheumatic heart disease. And that's it about rheumatic heart disease. Hello, can you still hear me? I'll post there if you have a question about rheumatic heart disease. Let me see if I can see the chat box in case there is a question. Well, hapa naona nikitoka sitaweza kurudi. Now it's telling me to stop sharing. I don't know. How do I access the chat box? Well, Shoaib, you can tell me if there are questions in the chat box. Hello? Is there anyone in this meeting?
Hello.
Yes, kindly. Can you tell me if there are questions in the chat box?
I think there's that question that was pointing towards vegetation. There's an arrow pointing towards the vegetation. You remember it?
Yes?
There's a diagram represented that there's an arrow pointing towards the vegetations. Someone asked, I don't know, something called the line of closure.
I didn't get that. Someone
There's-
asked?
I don't know, aliandika line of closure. I don't know what he meant by that. But I think it was going towards that question that that had the arrow.
Oh, okay.
Yeah.
What? Okay. Yeah, maybe you can unmute and ask.
Yeah.
So the red arrow, that red arrow pointing towards those vegetations are Verusai. Well, maybe they can clarify the question, but in the meantime, so we'll move to the next bit. So this one will go fast because it was already discussed in previous sessions. I remember Husseina discussed ischemic heart disease during some time. She was presenting something on a question that they had done. So we'll go fast in this one. Ischemic heart disease. Yeah, you all know what ischemia is. All right? Heart disease. All right? So when you're talking about ischemic heart disease, this is a syndrome caused by an imbalance between perfusion and myocardial oxygen demand. When you're talking about ischemic heart disease, we are mainly concerned with the myocardium, okay? Because remember, your myocardium is what contracts and relaxes to give you that systole and that diastole that you have, okay? So every time your heart contracts, that energy that it contracts with, it needs a lot of energy to contract and keep your heart pumping, and pushing blood to all the other regions that are required, to all the other regions where oxygen and nutrients are required, okay? So remember, your blood is the medium in which the nutrients, your glucose, your proteins, all these things are contained in your blood. So your myocardium has to contract. So the myocardial contractility is very important in this case, okay? So when you're talking about ischemic heart disease, we are saying it is a syndrome. Because when you're talking about a syndrome, it is okay. So when we are talking about a syndrome that is caused by an imbalance between perfusion and myocardial oxygen demand, remember, this is a muscle, okay? Therefore, it requires high oxygen and energy supply, all right? Therefore, if we have an increased oxygen demand and we cannot meet this, we are going to have an imbalance, okay? So the muscle is not going to be perfused, or it's going to be inadequately perfused. If it is inadequately perfused, then it's going to die, going to undergo necrosis, and it cannot contract as normally, and therefore we are not going to have perfusion in the muscle as well as in all the other parts of the body where this blood is needed, okay? So basically your heart will be failing, and if your heart is failing, then your body will be failing, okay? So what's the effect? Okay, what's the effect of ischemic heart disease or I think somebody needs to mute. Okay, somebody needs to mute. All right. So what is the effect if we have an imbalance between perfusion and oxygen demand? For example, if you have the left ventricular hypertrophy, I think somebody needs to mute.
Adam Haji. Continue, Abdurrahman.
Okay. So we were saying ischemic heart disease is a syndrome caused by imbalance between perfusion and myocardial oxygen demand. So I'm asking myself, or what we are asking ourselves is, what is the effect? For example, if you're having a left ventricular hypertrophy, so the left heart has hypertrophied, and the amount of blood that is needed to be supplied to this heart muscle is not adequate. So that muscle is going to be lacking in nutrients, lacking in oxygen. And if it is lacking in oxygen and nutrients, then it is not going to be contracting as normal. If it fails to contract as normal, then we are going to have what we refer to as myocardial infarction. Then we are going to have angina. We're going to get sudden cardiac death and all those other consequences. So, I think somebody needs to mute. What is the main cause of ischemic heart disease? Okay, so what is going to cause this ischemia? So what is going to happen that is going to lead to this myocardium failing to get perfused adequately? So the main cause is coronary atherosclerosis. Remember, the myocardium. Remember the blood supply to the heart. The blood supply to the heart is usually from the outside towards the inside. So in any case, if you are going to have hypoperfusion, so the inner part of the inner part, that is the lumen of the left ventricle or the ventricles, is most likely not going to be affected, because as the blood is emptying into the this noise is I think the host has ability to mute. Okay. So I was saying, when you're talking about perfusion or blood supply to the heart, it usually happens from outside towards the inside. So the left anterior descending, the circumflex, the right carotid artery, the right coronary artery, all these supply blood from outside towards the inside of the myocardium. Okay, so usually the inner part, it is not entirely supplied or majorly supplied from the outside, but from the inside, because remember, the blood is flowing through the lumen. So the inner part of the myocardium is supplied. And that is why even when we'll be having necrosis or ischemia, it is going to be so much worse from the outside. Okay. So therefore, we're saying that the main cause of ischemia is coronary atherosclerosis. So we're having a thickening and narrowing of the coronary arteries due to the deposition of cholesterol. And when we have the deposition of the cholesterol, we have the thickening and reduction in the lumen of the coronary arteries, and therefore the amount of blood supplied to the myocardium will go down. Okay, and therefore this coronary heart disease or the coronary atherosclerosis is going to be the main cause of ischemia. And this does not happen overnight. It happens over a long period of time. And that is why one of the risk factors of getting myocardial ischemia or myocardial infarction is age. Okay, so it's not very common to find a young person getting ischemic heart disease due to coronary atherosclerosis. This happens in later stages of life. So the clinical divisions of ischemic heart disease, that one you can go look at it. But basically, when you're talking about clinical divisions, these are based on the clinical features and the severity of the ischemia and the duration of the ischemia. Okay, so one will have myocardial infarction. Okay, so based on the ischemic severity and the duration, is it enough to cause myocardial necrosis? Yeah, because when you're talking about ischemia translates to necrosis, and that is what we refer to as myocardial infarction. So when you're talking about myocardial infarction, the ischemia must have been severe and must have been there for a longer duration, enough to cause necrosis. All right. And then something else, angina pectoris, which is less severe and there is no necrosis because the duration and the severity of the ischemia is short. Okay. And the subtype of angina pectoris is stable, Prince-Metal, unstable, and all this you can see based on the EKG. Remember the EKG, the STEMI and then unSTEMI, that one you can go look at it. It's more of internal medicine than in pathology. Okay. So then we also have chronic ischemic disease and heart failure that has been there for a long duration, and then we have sudden cardiac death. So you've all heard about athletes, yeah, who suddenly collapse and die. Most of the time they die because of dilated cardiomyopathy, sometimes which is a consequence of ischemic disease, and alcohol, all those you can get in a patient who get ischemic disease. So what happens or what worsens ischemia? Okay, remember, ischemia is what happens when we have an imbalance between the myocardial oxygen demand and the perfusion that we are giving to the heart. Okay, so but what makes it worse? One is the decreased blood and oxygen flow. For example, what happens in shock? If a person gets hypovolemic shock, okay, usually the blood pressure goes down, okay, and therefore we'll be having, and if you've ever been to a ward where the patients are critically ill, for example, in IMED, and the patient is getting septic or hypovolemic shock, maybe the patient was highly dehydrated, had vomited, had diarrhea for long, and is getting into hypovolemic shock or septic shock in case of sepsis that is setting in, the low blood pressure translates to decreased blood supply and oxygen supply. Okay, so in cases of shock, ischemia will be worse. Okay, and again in increased demand. For example, what happens in hypertrophy? Remember what happens, like for example, in right-sided hypertrophy, that is as a consequence of mitral regurgitation and mitral stenosis, and then we have in right-sided ventricular hypertrophy. You are increasing the thickness of the wall, but the supply by the coronary arteries is not increasing. Okay, so what happens? There is an imbalance. You are hypertrophizing, increasing the size of the myocardial cells and increasing the size of the myocardium, but you are not increasing the supply, because remember the coronary, the left anterior descending, the circumference have not increased in supply. So the supply is remaining the same, but the myocardium is increasing. So what is happening? We're going to have an imbalance. So anytime we have increased demand, anytime we have decreased blood and oxygen supply, then the ischemia is going to worsen. Okay, then how does this happen? Okay, so usually, remember we said that the leading cause of ischemia is atherosclerosis. Okay, so usually what happens in atherosclerosis, for example, mainly when we're talking about the coronary atherosclerosis, we having an atherosclerotic plaque forming in the what? In the lumen of the what? Of the coronary arteries. So these plaques are usually stable, but for some reasons they become unstable. And if they become unstable, they dislodge. And if they dislodge, they are ferried. And where do they go? They are taken to the myocardium through the blood supply to the myocardium. And then when they get lodged there, then they cut off the blood supply. And then what happens? Ischemia strikes in. Okay. So usually we have a stable atherosclerotic plaques in the coronary arteries, particularly in the left anterior descending, the left circumflex and the right coronary artery. So in these vessels, we have stable atherosclerotic plaques due to cholesterol deposition. Then this plaque get disrupted, okay? And they get disrupted by erosions, ulcerations, fissuring, and rupture, and sometimes hemorrhage. And this causes thrombosis, and these plaques get dislodged. And then this sometimes happens in the case of exercise. So a person has been normal, yeah, but then all of a sudden, during exercise, these plaques get dislodged, okay? So when they get dislodged, and then this is what we refer to as the patient gets exercise-induced ischemia. And then even sometimes it can happen as rest because we are forming very large plaques, and these plaques are getting dislodged and they are coming and blocking the coronary arteries. And then the coronary arteries that are supplying the myocardium, now the supply is no longer there. And so what happens? We'll have myocardial ischemia. Okay. So then what happens that leads to these plaques getting dislodged? Yeah. Or what happens that leads to these erosions, ulcerations? Some of the triggers are the structure and the composition of the plaque. Okay. The blood pressure, the platelets activities, because remember, we're having thrombosis, we're having hemorrhage, we're having thrombosis happening. So the platelets have a role to play, okay? The blood pressures are going to lead to erosions. For example, if you have very high blood pressure, patients who have chronic hypertension, for example, if you see a patient with high blood pressure, why are they started on atorvastatin? Patients with hypertension, they're started on atorvastatin, which is what are we calling them? Statins, yeah? Lipid lowering drugs. You remember the lipid lowering drugs and how they inhibit the HMGA, the HMG, something reductase enzyme. You all remember this, okay? And how it was happening. So lipid lowering drugs are one of the drugs that will give patients with hypertension because these patients have high blood pressures and then they are having cholesterol forming in their vessels. And then these high blood pressures are going to cause erosions of this plaque. And then this plaque is going to get eroded, hemorrhage, and then thrombosis. And these thrombus are going to be thrown and blocking the coronary arteries. And then the blood supply to the myocardium is stopped, and this is what leads to ischemia. Okay. So plaque lesions, inflammation, endothelial cells coming into place, cytokines and T cells getting attracted, macrophages, remember, they also getting to come here because there's inflammatory reactions, and then the collagen is going to get digested in the plaque, and then inflammation. Remember, this is the immunology or what happens in the pathology or the pathophysiology of ischemic heart disease. Remember, one of the markers of inflammation is CRP, and if we are going to do an assay on a patient with ischemic heart disease, one of the things that we want to check is the CRP. Okay. So, and the CRP, it's not very specific. We cannot say that it is an indicator of heart disease, but in case of an ischemic heart disease, because of the disruption of the plaques and the inflammatory reaction that is going to happen, then we are going to have CRP getting elevated. Okay. So we have this thrombi formation, embolization, smooth muscle growth, then plaque growth, vasoconstriction, plaque disruption. Remember, this is an explanation of the pathophysiology of how the plaques get dislodged. Remember what the plaques we are talking about? Atherosclerotic plaques. Okay. Due to what? Due to deposition of what? Of cholesterol. And why are these patients having this? They're having this because these patients have hypertension, which is a peripheral vascular disease. Okay. So we are going to have very elevated blood pressures, And then we also have there's something else I wanted to say. These patients also have increased cholesterol. Remember, they have low levels of HDL, yeah, and very high levels of LDL. Yeah, remember in your biochemistry, not biochemistry, but clinical chemistry classes. Yeah. So patients who have hypertension, one of the assays we want to do is the lipid profile. Yeah. So this deposition of cholesterol, bad cholesterol, the low density lipoproteins is high with very low, high HDL. And what happens is that we have formation of these atherosclerotic plaques, and then these block the coronaries, and then we have ischemia. The subtypes of ischemic disease, angina pectoris, basically, clinically, is due to, we classify them, or the subtypes are due to, are based on the duration and the severity of the ischemia. Yeah. So, for example, angina pectoris, which happens 15 to 50, if you have ischemia of 15 seconds to 15 minutes. So then we have stable, or the typical is the main one, when it's due to stenosis in atherosclerosis and triggered by exercise, and happens also in emotions. Yeah, usually relieved by rest or nitroglycerin. Yeah, Prinzmetal, which is caused by vasospasm, and then it's uncommon and responds to vasodilators, and the unstable angina, in which there is pain with progressive increased frequency, occurs at rest, and it's precipitated by minor activity. Remember, this myocardium is getting ischemic. Yeah, the blood supply is kidogo. We are having low blood supply. In addition, you are exercising. Every time you exercise, you increase the demand. Anytime you increase the demand and you have reduced or constant perfusion, what is happening? We're going to have ischemia. Okay, so exercise, emotions, and minor activity in patients with atherosclerotic plaques, and this in the coronaries, this is likely to lead to ischemia, and the various type of ischemia based on the duration and the severity of the ischemia. So then myocardial infarction. This is what the lay people refer to as heart attack. And usually for us to call it myocardial infarction, the ischemia must have been there for some duration. Okay? And then characteristically, there must be death of myocytes. Okay? Because of severe ischemia. And then that is when we refer to it as myocardial infarction. So the ischemia has been there for some duration. Okay? And then this duration, because of the long duration of ischemia, and then the severe ischemia will lead to death of myocytes. Remember, these myocytes, they are the contractile cells. And these contractile cells are not getting supplied with oxygen and nutrients. So what do? They die. Yeah. So whenever we have death of myocytes, we no longer refer to it as angina or whatever those STEMI, ischemic, but rather we call it as myocardial infarction, because we have death of myocytes, because the ischemia has been severe. So usually here, a third to a half of the ventricle is involved. Remember what we said about the blood supply to the heart. It's from outside towards the inside. So most of the times, the inner part of the myocardium is usually spared. Okay, because it is getting blood supply from the inside as well. So it is getting some anastomosis of blood supply from the outside and from the inside. And when you're talking about the inside, we are talking about the lumen of the ventricle. Okay, so this happens due the heart attack or the myocardial infarction due to occlusion of the coronaries and intense vasospasm, platelet aggregation, thrombosis, and emboli. Remember, we've talked about all this. And then there is loss of contractility. Remember, the myocytes are dying. And then if they are dying, we are losing contractility. If we have contractility, being lost in 1 minute is usually getting heart failure, and this is usually reversible. Yeah, if you lose contractility in 1 minute, it's usually reversible. But 20 to 40 minutes, it's irreversible. Yeah, we'll have microvascular injury. 6 to 12 hours necrosis. Remember, Husseina taught about this during the initial classes we had. 6 to 12 hours, we have necrosis. And what microscopic changes can we see in necrosis? The changes usually, remember what we learned in general pathology. What happens in cell death? Okay, the process of cell death. What changes happens in the nucleus, in the cytoplasm? Remember all these changes, 4 to 12 hours, there is light microwave fibers around the infarct. Okay, remember, if there is an infarct, an inflammatory change is going to happen. So light microwave fibers are going to be seen, and myolysis, yeah, and vacuoles degeneration. Okay, so the vacuoles degenerate, and then 2 to 3 days, there is inflammation, nuclear and striations are lost. Okay, remember, the smooth, the heart muscle is striated. Okay, remember the striations of the heart muscle, of the cardiac muscle. Okay, so the cardiac muscle has striations. So what happens in the 2nd to 3rd day? We have the inflammation, and then we have nuclear. The nucleus is lost, and then we have the striations are also lost. Remember the striations, remember the striated type of muscles. Yeah, so we have the skeletal muscle and the cardiac muscle. So both of them have striations. So in the 2nd to the 3rd day, the striations are lost. And then 2 to 4 weeks, granulation occurs, and then more than 6 weeks, we will have a scar. Because of what? Remember what happens? Anytime we have an inflammation, the body or the system tries to heal. Anytime we have healing with fibrosis. So there is scarring that happens after the fibration, after the inflammation. So in the 2nd to the 3rd day, we have the inflammation, the loss of the nuclear, and the loss of the striations. Yeah, and then to the second to the 4th week, we have the granulation, granular formation, and then more than 6 weeks, we have a scar. Yeah, or fibrosis, healing with fibrosis. All right. What clinical features do you see in a patient who is getting ischemia? One is dyspnea. Yeah, remember, these patients are not able to contract the heart very well. So they are unable to do what? They are unable to supply blood in all the body, in all the parts of the body very well. So what happens? The respiratory system is trying to compensate, yeah, for the reduced supply. So what does it do? There is increased breathing, yeah. So patients will be having labored breathing. So we have dyspnea, then we have profuse sweating because of the vasovagal response or something. And then we have a weak rapid pulse, everything trying to compensate. And then in the complications, the left ventricle is trying to do what? Is trying to hypertrophize. So remember, hypertrophy leading to ischemia, and then because of the hypertrophy, there is dysfunction. Because not the ischemia, the hypertrophy, but the ischemia, the contractility has reduced. Because of the reduced contractility, there is dysfunction. If there is dysfunction, the pressures that are required to be generated to pump blood are gone, or they are reduced, and so what happens is hypotension. And then pulmonary congestion again, because we cannot pump blood again away, and then edema, and then of course, you're going to have sudden cardiac death. Okay, arrhythmias are going to happen. And why are arrhythmias going to happen? Remember, what was this called? The sinoatrial node. The other one was called the AVN. Their location next to the next to the ventricle, at the junction of the atria and the ventricle, the bundle of His, all of this, the blood supply is reduced. So what is going to happen? We are going to have arrhythmias. Okay. Then regurgitations, of course, are going to happen. And then the left ventricle enlarging, or the ventricles enlarging. And if they are enlarging again, we having ischemia, we're having necrosis, destruction of the myocytes, and these myocytes are components of the wall, and we are destroying them. So what happens? A cardiac tamponade is going to happen. The rupture of the ventricles is going to happen, and all of these are complications of ischemic heart disease. Okay. I think somebody should mute. What are the risk factors? The risk factors of getting ischemic heart disease, one is the risk factors of atherosclerosis. Remember, we talked about age. Yeah, the older you get, the more deposition of cholesterol, the increased risk of getting ischemia, increased risk of getting atherosclerosis and ischemia. Then sex, it's more common in males for some reasons, genetics, yeah, lifestyle, those people who have a sedentary lifestyle, those people who don't exercise, those people who have poor diets that are rich in fats, and then hyperlipidemias, smoking, of course. Smoking has increased risk of causing hyperlipidemias, DM, homocystinemia. All of these are risk factors. Remember, this question, in a time they'll bring this question in pathology, they'll ask you about risk factors of ischemic heart disease. Yeah. And the risk factors of ischemic heart disease are the risk factors of atherosclerosis. Then sometimes we get chronic ischemic heart disease for those patients who get recurrent MIs. Yeah. So these patients who had a prior MI, this progressive heart failure with the decompensation, we get chronic ischemic heart disease. Grossly, this patient will be having a large heart because of hypertrophy. Okay. Then they'll be having stenosing, atherosclerosis again, discrete gas scars, and this, of course, you see in postmortem. Yeah. Microscopically, we're going to have the myocardium, myocardial cells. How do you call the myocardial cells? Yeah, the myocytes will be larger. Then we'll be having fibrosis and scars and diffuse endocardial coagulation. So this is what you're going to see microscopically. And then sometimes we have sudden cardiac death. And these are from complications of ischemic heart disease mainly. And this happens usually within 1 hour of symptoms. You'll see a patient profusely sweating, and all of a sudden they have dyspnea. And then, so they have dyspnea, increased palpitations, and the pulse are bounding, and then they are sweating, and then within an hour, the patient is gone. Yeah. And of course, the other causes of sudden cardiac death are arrhythmias other than ischemic heart disease. So ischemic heart disease can lead to sudden cardiac death, and the sudden cardiac death happens within. Somebody needs to mute. Well, we have come to the end of ischemic heart disease, unless somebody has a question. Somebody is really having their mic on. I don't know. What should we do? Hello, can somebody mute? Host, hauna powers za kumute mwenye microphone yake iko on? Okay, so on the ischemic heart disease, we have a question here. So what pathology is this? Well, this is a vessel. The description is that you can see yellow coloration. What is the color yellow indicating? It is indicating cholesterol. These are lipid streaks. Yeah. So this is a lipid streak, and this is common in atherosclerosis, which is a risk factor of ischemic heart disease. So then again, you can see this again. What can you see here? So I got this diagram from WebPath. So you can go look at it when you are revising. So what can you see here? Again, this is a vessel with cholesterol deposit. What heart disease is likely to result is ischemic heart disease. Then what about here? What happened? You can see this is the left, this is the ventricle. You can see areas of hemorrhage, areas of, this looks like clot. Yeah, you can see the dark areas, you can see the red areas, areas of hemorrhage, areas of ischemia. What is the most likely effect? This is a cardiac tamponade. So the left of the ventricle wall has ruptured. Yeah, so you can look at that during your own time. Lastly, I know you're very tired, but let me move quite fast. The last bit is hypertensive heart disease. So the reason we are supposed to look at hypertensive heart disease, remember, hypertension is one of the most important diseases that we have currently. I am currently doing an electives at a certain hospital, and in the medical ward, I think out of 38, in that ward, out of 38 patients in the male medical ward, 11, is it 11 or 12? I think 13 patients have hypertension. Yeah. Complicating now with heart failure, ischemic strokes. So hypertension is a very serious disease. It's a very important disease, especially in our setting. So it's important to understand the hypertensive heart disease. Okay. Because every time you are seeing hypertension, you should always think about the consequences of hypertension. Not about the exams only, but you should also be thinking about it for your care of your patients. Every time you see a patient with hypertension, always think about their sequela. What likely are they going to get? Yeah. So I think out of those 13 patients we have in the ward, like only 2 were admitted because of hypertensive emergency. One because of hypertensive urgency, another one hypertensive emergency. I think the rest have CVAs. So you can see how serious it is. So not only for your exams, but every time you see, we think about hypertension, think about it keenly or more in details, because you're going to find a lot of patients with hypertensive heart disease. So hypertensive heart disease can be systemic or pulmonary. Yeah. So you have systemic hypertension and we have pulmonary hypertension. Basically, when you're talking about hypertension, we are talking about high BPs, and it's based on recording of blood pressure. Yeah. 3 consecutive recordings of high BPs, more than 130, more than 135 or something. You can go look at the cutoffs. Okay. Systemic, when you're talking about systemic hypertension, we have a pressure overload in the peripheral vessels. Okay. And usually in the peripheral, remember, in the peripheral vessels, we're talking about the blood that is leaving the heart, getting into the system. Okay. So when you're talking about blood leaving the heart, where is it leaving the heart from? It's leaving the heart from the what? From the left ventricle. So every time we be having high pressures in the peripheral vessels, so this will be causing the left ventricle to adapt, okay? Because of the pressure overload in the peripheral vessels. Because the left ventricle has to pump blood against high pressures in the peripheral vessels through the aorta, through the abdominal aorta, through all the aortas that we have, and the sub-branches of the aorta, all the way to the tibial, all the way to the dorsalis pedis, everywhere, yeah? So sometimes when we have sustained hypertension, we will have myocardial dysfunction, okay? And if we have myocardial dysfunction, then we'll have cardiac dilatation, okay? We have sustained blood pressures, and then the myocardium is trying to contract and pump blood against the very high pressures. So the myocardium will they'll be having myocardial dysfunction, and therefore will be having decompensation, okay? And then the cardiac dilatation and congestive cardiac failure. And so consequently, we're going to have sudden death, okay? Every time you see a hypertensive patient, you think about acute decompensated heart failure. The acute decompensated heart failure leads to sudden death, okay? Sometimes, because when you're saying a patient has acute decompensated heart failure, most of the times you'll find that they have systemic hypertension and pulmonary hypertension. And so Professor Joshi once asked me, when I think during my end of rotation exams, I happened to meet him and I was so scared. And he asked me, what is the mainstay treatment for this patient? A patient has features of acute decompensated heart failure in a patient who has sustained systemic hypertension, of course, debunking this onto onto the pulmonary system. So the patient had both systemic and pulmonary hypertension. So I was asked, what is the mainstay treatment? And I couldn't tell. So I was telling him that we should manage the exacerbation, which is true. But he told me that's a lot of nonsense and told me that this patient actually needs your heart and your lungs. So you should, every time you think about hypertension, you should be very concerned, because every time this patient has, they are not taking their medications very well, they'll always come with acute decompensated heart failure with the features of exertional dyspnea, peripheral edema, features of cor pulmonale. So, well, always think about it in details every time you think about hypertension, not only for the exams, but because you need this information so much outside here. So, grossly, in a patient with hypertensive heart disease, what are you supposed to see? Remember, we don't have hypertrophy here. We don't have hypertrophy of the left ventricle. Instead, we have dilatation of the left ventricle. So because of the dilatation, the heart enlarges. And that is why when you are examining a patient with hypertensive heart disease, one of the things you are supposed to look for is the apex beat. On your palpation of the apex beat, most of the times it will be displaced. Yeah, so we no longer feel your apex beat at the 5th intercostal space mid-clavicular. Instead, it will be going laterally or sometimes even medially. Okay, so sometimes I examined a patient and the apex beat was mid-axillary. So you can see how displaced it was. So grossly, you'll have cardiomegaly, more than 500 grams. You can go and look at the normal range of a normal heart should be what grams. So then the left ventricle again will be thicker, more than 2 centimeters. Atrial enlargement, of course, is going to be happening. And then microscopically, there is increase in the transverse diameter of the myocytes. Okay. Then cellular and nuclear size variation and interstitial fibrosis. This one you're going to see microscopically. Then clinical features. It's important for you to remind yourself. Sometimes patients with hypertension have no features, and that is why they don't take their medications. So as a clinician, okay, this is not part of this lecture, but because you're going to be part of this discussion, but as much as we are revising for exams and preparing to pass exams in pathology, always think about your patients. Okay. So most of the times I see a patient with hypertension. One of the most important things I always think about telling them is how to be compliant to be their medications. Because a patient will come with very high BPs and then he's newly diagnosed hypertension. And because they are asymptomatic, they no longer take their drugs. You will give them your losartan, CG, your whatever, your carvedilol, CG, what, hydrochlorothiazide. So you'll give all those medications, but the patient will go home and they don't take them. So as part of your training, as part of our training, we should tell patient or teach patients to be compliant to their medication. Sorry, I went offside, but it's important. Initially, patients with hypertension, they have no symptoms because the left ventricle is trying to compensate. Okay, but later they get decompensation. Okay, so they are going to be getting features of heart failure, which all of you know. Okay, and then they get complications. Okay, so atherosclerosis, ischemic heart disease, heart failure. You know, patients with heart disease, especially with hypertension, their renin-angiotensin system will be highly activated. And that is why one of the drugs we give is ACE inhibitors. So patients with hypertension, they are likely to have atherosclerosis, ischemic heart disease that we've already talked about. This patient will eventually get heart failure. And because of the decompensation, remember, when you're talking about acute decompensated heart failure, there is no compensation. So what happens? There is end organ damage. And that is what we see in hypertensive emergency. In hypertensive emergency, the difference between hypertensive urgency and hypertensive emergency is that in hypertensive urgency, the BPs are high roof, very high, but there is no end organ damage. But with a hypertensive emergency, there is end organ damage. So your brain is affected, the patient is coming with ischemic stroke, or the renal system, the kidneys are affected. Your patient is getting acute kidney injury, and you have to hydrate very fast, or else the creatinine and the urea are going to get high roof and they are going to destroy the patient's kidneys completely. So the renal, the brain are all affected, and sudden cardiac death is one of the complications of hypertensive heart disease. That is systemic heart disease, or the left-sided heart disease. Then, when you're talking about pulmonary hypertension, so here we have pulmonary congestion. Yeah. And because of pulmonary congestion, what is going to happen? Your right ventricle has to hypertrophize and to try to pump blood. And when it can no longer hypertrophize, what does it do? It dilates. And so it fails. Yeah. So pulmonary hypertension is going to lead to right-sided heart failure. And this is what we refer to as copulmonale, which is one of the common complications of pulmonary diseases. Remember, every time you see a patient with COPD, every time you see a patient with PTB, every time we see even a patient with pneumonia or a lower respiratory tract infection, this can lead to a right-sided heart failure, which is copulmonale. But other than the pulmonary features, we can also have heart disease, hypertension, leading to right-sided heart failure. Okay, so sometimes It's chronic, sometimes it's acute. In the acute phase, in the acute type of pulmonary hypertension, it's caused by pulmonary thromboembolism. Remember, every time you see a patient with DVT, okay, a patient who have been on an overhaul flight, a patient who are immobilized, patient who have undergone surgery, females who are on contraceptives, all these patients have a risk of stasis. Okay, they have stasis, a risk of stasis. You remember the three, what were they called? The virtuous triad. Remember the virtuous triad, stasis, and the other two. Remember, every time you see a patient with those risks, they are going to have a risk of pulmonary thromboembolism. Every time they have a pulmonary thromboembolism, a clot in the pulmonary vessels increase pulmonary hypertension, and that is what is happening acutely. Yeah, a PE, pulmonary embolism. Okay, then chronically, we have pulmonary artery overload due to obstruction, sometimes leading to compression, and then the right ventricle has to hypertrophize. So grossly, what are you going to see? In the acute phase, you're going to see, in the acute form of the disease, you're going to see right ventricle dilatation. Usually it's over, but there is no hypertrophy. And then we have in the chronic, we have the right ventricle hypertrophy, and usually it's 1 centimeter or more. Okay, not like in the systemic hypertension where it's more than 2 centimeters because the hypertrophy is more. And then the muscle bundles, sometimes they get thickened, and that is what you can see. What are the causes and the complications of pulmonary hypertension? This one, you can go look at them. But common causes, especially pulmonary hypertension that is acute, is pulmonary thromboembolism and pulmonary hypertension. However, for chronic cases of the pulmonary hypertension, we'll have things like COPD, yeah, interstitial lung disease, bronchiectasis. Yeah, remember, every time you see a patient again with TB, they can get TB bronchiectasis. Yeah, so you're going to have all those bullae forming in the lungs. Yeah, and then the patient will be having purulent sputum. Yeah, so you can go look at that. And then things like kyphoscoliosis, because they are reducing the anterior posterior diameter of the rib cage. Okay, so pulmonary arterial constrictions. What are the complications then of the pulmonary hypertension? So we have congestion, yeah, then compression of the left ventricle, tricuspid regurgitation. Remember, the right ventricle is trying as much as it can. Yeah. So the tricuspid valves can get, so the tricuspid valve, because remember, we are unable to pump blood enough, and then we are having backflow, regurgitations happening sometimes because of the inflammatory reactions. We have fibrosis, stenosis, and all these complications. Well, that's it about pulmonary and systemic hypertension or hypertensive heart disease. So this is adapted from the slides of Dr. Wawero. What can you see? That is the left ventricle, and we can be able to tell it's the left ventricle because of the very thick walls. Yeah. So what can you see? Concentric left ventricular hypertrophy, thickening of that wall, and this is in hypertensive heart disease. So you can go look at it. Then what happened here? What can you see? This is the ventricle again. thickening, so much thickening, decompensation. When there is decompensation, dilatation, the dilatation leads to rupture, and that is cardiac tamponade. Shukran. That is the end. I'm so sorry that it was a very long one. Can you still hear me? I lost everyone. Shukran. May Allah guide us all. That's the end. Hello.
Hello, we can hear you. Thank you.
I'm so sorry for taking a lot of time. Now I can take questions in case you have.